This presentation provides an overview of important principles to consider when undertaking joint examinations. It specifically focuses on the 28 Disease Assessment Score and principles of good clinical practice. Once adequately trained, the examination can be carried out reasonably quickly in the busy clinical setting. A recognised validated method is that of the 28 Joint Disease Assessment Score, which includes an examination of 28 joints for swelling and tenderness. The swollen and tender joint counts are combined with inflammatory markers such as ESR or CRP and a patient-completed visual analogue scale of global health. This information is combined to provide a composite score known as the DAS28. It's important that we have ways to assess patients' levels of disease activity. We are now going to look at a patient being examined and discuss some key principles that should be considered when undertaking a DAS28 joint examination. Important aspects of good clinical practice start before you actually examine the patient. Observe the patient as they enter the room. Are they walking easily and comfortably? Or can you see functional difficulties? Do they sit down easily without the use of the arms of the chair? In order to complete the DAS28 joint count scoring sheet, you need to record each swollen and tender joint. When completing the global visual analogue scale, it's important that the patient fills this in themselves and you ask them how they have been in the last week with their arthritis. Get them to mark the line on the visual analogue scale. Where possible, the assessment for joint tenderness and swelling should be undertaken at the same time to reduce the level of discomfort to the patient. When you're looking for joint swelling, it's important for you to know what to look for. Joint swelling is soft tissue swelling of the joint, which is detectable along the joint margins. When a synovial infusion is present, it invariably means the joint is swollen. Neither bony swelling or deformity or edema surrounding the joint constitutes joint swelling. Joint swelling does not include nodules such as these. Fluctuation is a characteristic feature of swollen joints. Joint swelling may influence the range of movements. This can be useful when trying to decide the presence of swelling. Examples include decreased dorsiflexion of the wrist and limitation in the elbow extension when joint swelling is present. Remember, joint damage may also limit range of movements. It's helpful, although not essential for the DAS28, to assess the warmth of the joint. If active synovitis is present, the joint will be warm to the touch. In order to avoid your own body temperature affecting this assessment, use the back of your hand from the midpoint of one joint to the midpoint of another. Ask the patient to move the joint themselves to identify tenderness on movement where possible. When moving the joint yourself, this is called passive movement, ensure you take the weight of the joint and provide adequate support. Always apply the golden rules of observe, look for obvious signs of deformity, swelling or pain at rest. Before you start examining the patient, make sure they're comfortable and joints are well supported throughout the examination. When they're taking off their clothes, look to see the range of movements that they have and whether again you can see any tenderness or discomfort on moving. Discuss with the patient which joints are particularly painful before you start the examination. You may be able to get the information about the tenderness without putting them through a lot of discomfort that way. To ensure that you are pressing sufficiently to elicit tenderness, you need to make sure that you press with your fingers hard enough so that you can see the whites in your nail bed. When moving the joint yourself, you should ensure that you observe for any visual clues of tenderness, such as guarding the joint or facial expressions. Sometimes you may see them withdraw the joint, anxious about being examined. On examining the metacarpal phalangeal joints, you need to ensure that you look carefully for fluctuation. Use supporting hand to keep patient's hand extended, with metacarpal phalangeal joints flexed at about 50 degrees. Support the patient's hand comfortably with your own fingers underneath the patient's hand. Examine each joint in turn. When examining the PIP joints, you need to place your fingers carefully, as shown here. Feel right and left anterior joint margins with the examining hand using thumb and index finger. Examine each joint in turn with the patient's hand extended. Compare joints when looking at the wrist joints. Compare both wrists together before you start the examination. Examine extended wrist in neutral position. Use both hands to examine with thumb on dorsal aspect of patient's wrist and fingers on plantar surface of patient's wrist. The margin of the wrist has been carefully palpated and you can see the pressure that's being applied. Another option that's not recommended in the DAS28 but is sometimes useful to use is the squeeze of the metacarpal joints. This will show you if the patient has any tenderness in the metacarpal phalangeal joints. The prayer sign might also be helpful to see what limitation the patient has in their range of movements. When you're looking at the elbow, look at the position on resting and on movement. Compare both elbows. Flex between 70 and 80 degrees. This will depend upon the range of movements the patient can achieve. Joint damage can also limit movement. Place index fingers in antecubital fossa. When examining for joint tenderness, it's important that you know pain at rest without pressure should also be included. Pain on movement of the joint should also be taken into consideration. For instance, moving the shoulder. Although not required for the DAS28, examining the metatarsal phalangeal joints is important in clinical practice. The squeeze test for tenderness is a quick and useful way of eliciting tenderness in the MTPs. When examining the knees, make sure the patient is comfortable on the examining couch and well supported so they will relax. Adjust the height of the couch so you can examine easily. Compare both knees and note alignment. Make sure you also look carefully at the posterior aspect of the knee joint. Effusions can also be detected here. Use one hand to evacuate the suprapatellar pouch, as seen here. With the other hand, place the thumb and middle finger along the medial and lateral margins of the patellofemoral joint to look for fluctuation. You can also stroke the medial or lateral aspect of the joint with your hand and observe for the bulge as fluid moves on the opposite joint margin, as you can see here. On this second knee, you can see some joint changes, but also a small effusion. Examination of the ankle is not recommended in the DAS28, but useful in clinical practice. The same principles of examination should be applied. You should ensure that you check for range of movements in the ankle to see if there's any disability or lack of function. Examining the joint for fluid and tenderness again is important. You can see here fluctuation and clear joint swelling. We now have all the information required to calculate the DAS score. You will need the completed joint examination sheet with tender and swollen joints documented, blood results for the CRP or ESR, You will get an objective measure of the number to use for the visual analog scale by using a ruler. You then use the calculator to feed in the information, and this will come up with a composite score for you. This composite score is the DAS28 score for your patient. Just to remind you of a few key points. You must work together as a team to agree subjective elements of the joint assessment. You need to practice plenty of examinations with others and compare scores. This video has been produced by the Royal College of Nursing Rheumatology Forum to aid practitioners in examination technique using the Disease Activity Score 28 joint count. It's for educational purposes.